Thank you so much for staying with us. And in case you're just joining us, we have shifted gears. It is Wednesday, and every Wednesday, we take time here to discuss matters health, talking about policy, talking about state of affairs, and even different conditions and how better to manage them. So today, we want to look at the issues. And I have a panel of two gentlemen. Of course, it's supposed to be a panel of three, but allow me to introduce Peterson Wachira, who is at the center there. Peterson is the chairperson of the Kenya Union of Clinical Officers. Thank you for creating time.
Thank you.
And also with us is Dr. Willis Ahwale, a public health expert that has served in very many pivotal roles in our health sector, including even advising the government on matters malaria. Thank you for creating time this morning. We're also expecting Dr. Brian Lishenga. He's the chairperson, Rural and Urban Private Hospitals Association, and he will be joining us in due course as we continue to engage on the state of healthcare in the country this particular morning. Let's begin by, the latest development, just to get it out of the way, because it has elicited a lot of reactions, is an executive order that was issued by the US President Donald Trump that speaks to the fact that there are plans to withdraw from the World Health Organization. So he signed an executive order to withdraw US from WHO. And this has sort of, for a better part of yesterday, it was a big conversation in the health sector on how this is going to impact not only the US, but even other countries that are associated with World Health Organization, considering its financial standing within WHO. I want to hear your thoughts on this impact and if it is as big as others see it. Let me begin with you, Dr.
Okay. Yeah. Thank you, Safin, and thank you, everybody in Kenya. Good morning. Yes, yesterday we woke up to this news about US pulling out of the World Health Organization. In my opinion, I think it's an unfortunate decision. And we must look back to the 1948 when World Health Organization was formed. And go to the foundation of it, it was to really ensure that coming from the Second World War, with the challenges of then a lot of diseases, a lot of epidemics that were occurring, we had a concerted effort to make the world a safer place, and that we needed each other to protect each other. And yes, US has played a very critical role in the World Health Organization. I've had an opportunity to serve on some of the technical committees. We've tapped into some of their top sciences there. And more importantly, also some of the resources they have provided to ensure we implement some of the programs. Some very critical programs, for example, touching on infectious diseases like HIV, AIDS, tuberculosis, and malaria, but also pandemic preparedness. And if you look at these diseases, if we do not have a concerted effort globally, then nobody is safe, including the people who may be trying to pull out.
All right. Peterson, what are your thoughts? Some see this as a clawback on the international efforts to fight the health crises that we have experienced. What are your thoughts with the US withdrawing from WHO?
Yeah, it actually is, because, and thanks for having us so that we can be able to discuss these important issues. Let me say that, as you have said, it's a clawback. I happened to have been in the fight against Ebola. And one of the major players in terms of surveillance, in terms of capacity building, in terms of even restructuring was WHO. So the world cannot do without WHO, in short, because WHO provides experts that help countries in terms of policies, whether we are talking about policies on surveillance, policies of multi-drug resistance and antibiotic resistance, whether we are talking about policies in terms of capacity building of the health systems. And especially for those countries, the third world countries, and those countries who are incapable of probably getting some experts, high-level experts who can be able to shape this, they have almost completely been reliant on WHO. Now, when a major funder like the United States pulls out, Of course, the greatest impact will be to the third world and those countries that cannot be able to support themselves in terms of the things that WHO does. But then it's also a risk to them because we are traveling there. If then surveillance suffers, which means that we can have another outbreak somewhere and it's not picked in time, it will still end up there. And so I think any efforts that go against the global efforts to come together in terms of ensuring that we can have global surveillance systems, because that is the most important thing. And even when we talk about the universal health coverage, it's a program of the WHO under the UN, and they have also provided their expertise to capacity build countries to be able to do this across the globe. So I think it's a case of throwing the baby with the bathwater for the US. I think it is going to have a repercussion even against the same nation. And we can only hope that probably they'll be able to change their minds and get back on track.
All right. So how do we? What's the way forward as we close that conversation? Because for me, I look at this as a wake-up call. Today could be the US. Tomorrow it will be another giant within the WHO. And we all agree that this has ramifications, even especially for the developing countries that are relying on WHO for expertise, for financing, and all that. So, what do we do to cushion ourselves from such vulnerabilities? Should the trend continue?
Yes, I think it's a wake-up call, and I agree. And for many years in the public health sector, we've been discussing about sustainability. We've always been saying there's going to be this time when the donor funds will dry up. And there have been discussions at high political level. And there's been emphasis on a number of issues: increased funding for the health sector. There's been the clarion call about the Abuja Declaration, 15% of the GDP should go to health financing. There has been the issues of local manufacture of essential supplies and commodities. Remember, a lot of the money that comes from the US actually goes to ensure that we have the essential supplies and commodities. So the wake-up call should be, how quickly do we move towards this? There should be no waste of even 1 minute. Remember, lack of some of these essential supplies will lead to a death. That is why people should not take this lightly, because a death that could have been prevented because malaria is treated is just one too many. For me, I think the wake-up call should be, number one, what is our contingency plan if this happens to ensure nobody dies? And number two, how do we move forward without over-depending too much and waiting to only get support from these donors?
All right, I'll stay on you as we come now home and look at what even we are talking about this morning, the state of our healthcare. And I'll begin with you, Dr. because I know as clinical officers and even other cadres in the health sector, there is a lot that they have raised in the recent months. But if you were to give us a diagnosis this morning, Dr., what would be that diagnosis you'd give us about the state of our healthcare today?
No, I think the state of our healthcare, we must first celebrate a lot of steps we've done. We look back and even the last 20 or 30 years, you see even just one key indicator like the life expectancy of Kenya, it's improved. 20 years ago when I was now getting active into the public health, the life expectancy was very close to 50 or 52. We are now talking of about 66 years. That's when a Kenyan is born. They expect to live 66 years in Kenya. It means certain things have been gotten right. We've been able to control some of the leading infectious diseases. We've been able to ensure that there is vaccination programs for children. We've been able to ensure that certain services, core services like maternal health, women are not dying as often, and indeed, maternal mortality rate, that is a mother giving birth, dying while giving birth, has actually come down to about 350 per 100,000. And same with child mortality rate. It's also significantly come down because of the efforts that have been put in place. We've seen efforts by government to ensure that there's infrastructure. But all I can say is that efforts need to be more than doubled if we have really to achieve some of the global goals, and if we really have to ensure that then the public starts feeling the impact of the services that the nation is giving.
All right. If I had that diagnosis in my hand, I would say, it's not looking that bad. You know, Dr. diagnosis isn't that bad, but Peterson, you'd think otherwise. I mean, the very latest development is what some have termed an industrial action that is long overdue. What is the problem, and what are your big concerns? And this is not the first time that clinical officers are out in the streets calling on the government to act on their grievances. So just take us through what seems to be the quagmire right now.
Thank you. And maybe even going to that first question, let me say that we need to look at when you're looking at whether the health system is working or not, we must look at the regulation, we look at the funding, and then we look at the health service itself, because they're intertwined, and those three must be aligned for us to be able to get to our destination, which is the universal health coverage. When it comes to funding, we are not doing well. We are really doing badly. When it comes to regulation, we are doing excellent. We have the best laws on the land, we have the best policies, we have the best guidelines. In fact, other countries are borrowing them and actually doing better. But then when it comes to the service, and this is where we have an issue, and this is the reason as to why we are in a strike. When it comes to service, you must look at it based on three principles of the universal health coverage. Number one is every Kenyan able to access health care from where they are? And affirmatively, I can say no. Why? Is there a legal hindrance? No, there isn't. What there is administrative policy decisions that have been made by a few people that are denying Kenyans access. And this is the reason, actually, one of the reasons as to why we are on strike, because for some very funny reasons and some logic that is not understandable to us, a few people sat under the SHA board and decided that clinical officers cannot see Kenyans through the Social Health Authority. Mind you, the clinical officers see more than 90% of Kenyans, and under the same regulation, because every Kenyan is supposed to go through level 2, level 3 before being referred to level 4, where only clinical officers you'll find there as the clinicians, then it will mean that 100% of Kenyans cannot be seen by clinical officers. So, which we saw as self-sabotaging. Because when you tell people that we want you to give us 2.75 of your money so that we can provide to you health, but then you deny them access to the same, it's self-sabotaging. And that is why I'm saying that it's a logic that I'm yet to understand what those people are thinking. And this was done by them only saying that they were only going to recognize one of the regulatory bodies out of more than 10, which is the Kenya Medical Practitioners and Dentists Council, and which only registers medical officers and dentists. Even pharmacists, clinical officers, nurses, and everybody else was left out of the system. So that is why we came out, because we realized that whenever Kenyans were coming to see us as patients, then they couldn't use the system, because we are the people to see them. Across the board, up to level 6 in the outpatient, you are going to find clinical officers. So then people had to pay out of pocket. And that is why Kenyans have been asking, how come SHA is not working? Anytime we go to the hospital, we are told SHA is not working. Now, the other funny thing is that...
So it's working for... I want to understand something. How many facilities have been impaneled? You know, are you saying that it's working for those ones under KMPDC alone? And like, I want us to understand
Yes.
that challenge of empanelment, and how is it that you feel you've been locked out?
Yeah, maybe let me go back a bit and explain what empanelment means. Yeah. Empanelment simply means recognition, that I recognize this practitioner, I recognize this facility. Mm-hmm. This recognition is through your registration certificate and license. Mm-hmm. So you can only recognize that practitioner or facility after recognizing the regulatory body. So when they said that they were only going to recognize the KMPDC only registers medical officers and dentists. So it only meant that in that system, it would only recognize the practitioners, the medical officers and dentists, and their facilities. Now, for anybody else who is not registered by the KMPDC, it couldn't. And that is how now we were left out, because then the system does not recognize you. And now, but now, of course, after the strike, I think much water has passed under the bridge. We have been in talks. And I know from yesterday, now they started empaneling facilities by the Clinical Officers Council. And today and onwards, they are also going to now empanel the clinical officers so that they can be able to see patients. But I think the most unfortunate thing is that from October, we have been trying to make the ministry understand, and especially understand the repercussions to the patients. But it has taken demonstrations. You remember before Christmas, we were on demonstrations. Yeah. Now we had to go on a strike for the government to do something that is clearly logical and outright, and there is no legal hindrance. The law mandates the SHA board to recognize all the regulatory bodies that are recognized by the law, and after that, get a list of the practitioners and the facilities, put them in their website and gazette them. That is basically what is called empanelment, and then later, of course, contract them. So that is the first issue. The second issue that it has taken us on strike is a breach of the return to work agreement. Last year, Kenyans remember...
Before you get to the return to work agreement, let me also just hear your thoughts, Daktari, on this SHA quagmire. It's several months since the rollout of the transition into Social Health Authority took off. There's been a lot that has been said, where some people say it's working, some say it's still not working, some say the train has left the station, we can no longer go back to NHIF. You have advised and sat in very many technical committees that have addressed matters health. Do you think we actually took off before we were ready as a country, probably?
Okay, yes, I know in public health there's always been lessons learned. There's always been what we call piloting. In the recent past, people have been saying piloting can be very expensive, but we can always build. There's a time we say we need to go. If you look at universal health care, and in the last maybe 20 years, actually there have been several attempts. When Honorable Charity Ngilu was Minister for Health, she actually pushed that we move towards universal health coverage. And during that time, the challenge was, do we have the adequate resources? I remember I was then in the ministry, and the government, President Kibaki's government, was clear. That's a good idea. We'll go there when we have resources. In the recent past, under President Uhuru, we had the piloting of UHC in a number of counties. I remember 4 counties, including Kisumu, Makueni, Isiolo. I remember that. And there have been several attempts of UHC even by counties. So what I would say, we have a wealth of lessons that we've learned. But when you implement a huge public health program, then you must be prepared that it is not going to be an event. It's not one day. It is going to be long haul. So we must look at long-term goals, but we must be very clear what we want to achieve in year 1, year 2, year 3. And one of the best things then you do is come up with a very clear implementation plan that is shared. You tell people that in the first quarter, this is what we are going to achieve. And there will be challenges. You are not going to achieve everything. Then you need what we call a monitoring and evaluation framework and strategies. You must get a feedback. What is working, what is not working? And if it is not working, what needs to be done immediately and in the long term? And you must also have, within that implementation, monitoring framework, a feedback mechanism on the user. A public health program that does not meet the needs of the public is unlikely to succeed. The user must tell you, really now I'm feeling I can access healthcare as has been enshrined. So for me, what I see, it was good that we start the journey. But more important, therefore, is that we must be prepared to walk that journey in a systematic manner, addressing the challenges as they come. And I know one of the challenges we may talk about, touching on what Peterson has said, is the human resources for health. Yes.
All right. Which brings me to the point I was just about to say, you know, the return to work formula. And Peterson, we've been with you on this show before and talked about how human resource for health has been treated in this country.
Yeah.
I just want, first of all, to give you a chance to, you know, talk to us about this return to work formula. What was agreed, and why now, you know, seems like you're back on the drawing board.
Yeah. Please allow me to also maybe say something small about the same SHA. You know, the reason as to why SHA exists, and as Dr. has said, is to implement the universal health coverage. Universal health coverage has 3 pillars. One is access, the second one, of course, is protection from financial harm, and the third one is quality. The problem, and the reason as to why we have been calling for these people to be sacked and others to come in, we are very clear about that, is because they don't seem to understand, because there are so many hindrances they are putting on access that is also affecting the quality that Kenyans get, and then making people to pay out of pocket, which goes against protection from financial harm. And I think even as we go back, even as they empanel us, for us, we are not going to stop here. We must have an audit of what happened, because the things that have happened and the patients that have suffered, somebody must be able to account for that, so that if it is that they have no understanding, that should be enough reason for them to be censured and for other Kenyans to come in. We have so many experts who can be able to help this country to implement universal health coverage. But now coming to the return to work agreement, and the background is that last year we went on a strike for 99 days under county governments and 121 days under national government. That strike was informed by the fact that the employers ignored a court order to sit and negotiate. So when we went for that duration of time, the court, realizing the strike was protracted and was not probably bearing whatever the fruits the court wanted to, then the court ordered us again to sit with the employers and create a framework on how we are going to implement those issues. And that is how we got into the return to work agreement. In the return to work agreement, the things we agreed on was, number one, we were supposed to have done a collective bargaining agreement by 1st of September last year. We were supposed to have adopted the career guidelines for clinical officers and used it to promote and redesignate clinical officers by September last year. We were supposed to have medical cover in all the counties, comprehensive medical cover, and especially for those counties that did not have. We were also supposed to have had a mechanism to transition the contracted officers, whether the universal health coverage, the Global Fund, the CHAP, which is the COVID-19 emergency response staff, and the county-based contracts, because their pay is illegal. Their terms and conditions are illegal in that they are discriminated because they work with others, but they are paid less than half of what they are paid. And lastly, there were counties that had withheld pay. They were also supposed to pay. These are things that we agreed, and we agreed that by September we should have concluded.
That was September 2024, yeah?
2024. Both of us, the legal team from the Clinic Officers Union and the employers, both the ministry and the Council of Governors, went to court, registered this agreement. And I remember what the judge asked, Judge Bairam Ongaya. He asked 2 questions. First, he asked, did you enter into this return to work agreement in good faith? And they responded to the affirmative. Then he asked, are you going to implement it, or will you be back in court because now you have not implemented the same? And of course it was to the affirmative. But then several months down the line, 4 months down the line, counties had basically done less than 10%. And I think we must commend the national government under the leadership of the PS for Public Health, because the national government has done most of the things that needed to be done. We have negotiated a CBA. We have even initialized. It's only the Treasury and the SRC that is pulling us back. We have been promoted because I work under the ministry. We have a comprehensive medical cover that is under SHA, but it's also a subject for discussion because they extended without renewing the limits. So if you had exhausted your outpatient, they extended with the zero limit and people are not able to access. But now on the issue of the universal health coverage, the contracts, universal health coverage, the Global Fund, mind you, the Global Fund have been working for 6 months without pay. And you remember in 2024, because of that confusion and non-payment, there is a lady who got into depression and committed suicide and even took the life of her child in Nyeri. And I think these are the things that sometimes make us angry and make us go on strike because we do not want to lose another person because the government has not been able to do what it's supposed to be.
If you look at, Doctor, if you look at the concept of the universal health coverage, and you hear concerns such as what Peterson is raising, do we seem to understand this critical pillar known as human resource for health? And when we are dissecting it from your own analysis, how do we need to treat our human resource for health? Because this has been a discussion even on this show for quite some time.
Yes, a very good question and an important one. And I think if we are able to do this dissection on human resources for health, then we may just start getting certain aspects of UHC right. My feeling has been this component of human resources for health, which from my experience is so crucial to ensure the success of universal health coverage, has not been given the due attention. And I would want to look at aspects of it that would be very crucial towards UHC. And you start looking at just the numbers. If you are going to ensure success, then you must have a medical officer, a clinical officer, a nurse, a medical physiotherapist close to the population. That's when you talk of access. Therefore, you start asking yourself, do we have adequate numbers? And if you look at recommended ratio, for example, medical officer to patient ratio, nursing officer to patient ratio, clinical officer to patient ratio, like let's use medical officers for one. I know now there's 1 doctor to 5,000 patients, while WHO recommends 1 to 1,000. 1 doctor for 1,000 patients. Nurses, I think we are somewhere like 10.5 to 25,000 patients, while we should be at 25. It basically means we must double our nursing workforce. We must more than do 5 times of what the doctors are. These are the numbers, and there are certain what we call staffing norms. In the Ministry of Health, they will tell you a level 2 facility should have this number of clinic officers, this number of nurses, this number of laboratory staff. Level 3 should have this, level 4 up to level 6. And you realize we do not meet these standards. For that facility to function optimally, then there must be a mix of skills. You need somebody to diagnose what is the disease efficiently. So when I come to level 3, you should not tell me hapa sisi hatufanyi hiyo. You should adequately
everyone. Here.
Yes. So first the right medical personnel, the skills, but another component we must also consider then equipment and supplies. You need basic equipment to be able to know, do you have hypertension or not? You'll not be surprised to go to some of the lower facilities and the BP machine is not working. So I'm complaining of headache and I can't even confirm, is the pressure high or not? So human resource again goes very closely with the equipment and the people to manage the equipment. And the equipment cannot, I mean, you can stock equipment and people like having big functions when they're installing equipment, but if there is no human resource to do that, then you've done very, very little. And maybe something else I add. On top of human resource, you need what you call capacity development. You need to ensure the skills, the competencies. Technologies are changing, things are coming new. So you need to have a program that ensures the workforce's skills and competences are top-notch, and that is then going to start contributing towards increased access and quality of care, as was mentioned by Peterson.
Peterson, maybe we have not gotten to that point of understanding the role of clinical officers, yeah? And actually how many we have vis-a-vis how many we need, and whether they are working in the context within which even Dr. is painting for us, beyond the human resource. You need the supplies, you need the things to work, the tools of trade, if I may use that for lack of a better term. So what is the status right now if you look at the clinical officers? What is their role? Let's start there. And how many do we have? Do we have enough of those, or there is a shortage in that area as well?
Thank you, Safin. And what I can assure you is that they know the role. But maybe it's not that they don't know the role, it is because of other interests. But clinical officers, we usually work as primary clinicians. But also we have specialists. We have over 20 specialties. If you look at ophthalmology and cataract surgeon, if you have somebody operating on your eye and removing a cataract, there is a 98% chance that that's a clinical officer. If you find yourself in theater and you need to be anesthetized so that an operation can be done, there is a 95% chance that that is a clinical officer. If you are dealing with ENT, whether you are dealing with oncology, if you go into oncology centers, most of the people you are finding there giving chemos and such are clinical officers because we have that specialty. I think for the medical officers, probably I don't know if the first batch has graduated, but it has just started the other day. And we have 20 of those. We manage the specialized clinics. Most of the NCDs in the country, we are the ones managing. The HIV clinics, the TB clinics across the country, we are the ones managing. And whenever you go to any outpatient, at whatever level, the people who are going to see you are clinical officers. And that is why we are called primary clinicians, because we are the clinicians who see you first. And then, of course, secondarily, if you have to be admitted and followed in the ward, that is when you usually interact with the medical officers. And we work very well. We complement each other, and it is important to have what we call the right skill mix. So we have no problem with doctors. We work together with all the health workers in a complementary manner for the benefit of the patient. Now, traditionally, a clinical officer had been told to work where there are no equipments and where there is sophisticated equipment. So we are like the army. We can work in the village without anything. We were trained on making decisions and diagnosis without actually having the equipment. So that you have the most probable, what we used to call clinical diagnosis. But even before you come to that, if you look at the reorientation of the health sector, and that is why I'm saying we have very good regulation, because we are supposed to be preventing disease, and there is no nation that can guarantee people of their health if they cannot prevent the disease from happening in the first instance. Clinical officers in the past were taught in such a way that we attended barazas, we went to schools, we gave health talks to the communities, and we were able to do community diagnosis, family health diagnosis, and we would be able to pick the risk factors within the communities and homes and be able to prevent that. But because of the fact that the employment at some point was not commensurate with the population growth, then that meant that we became firefighters. We retracted back to the hospitals to cure diseases instead of also being able to prevent them. We have over 30,000 clinical officers in the country. Only about 7,000 are employed in the public sector. The others are outside. But if you look at the staffing norms and standards of 2016, 2014, 2018, as per the ministry itself, we were supposed to be having 16,148 clinical officers by 2018 in the public facilities. We are in 2024. We are supposed to be having around 22,000. clinical officers against 7,000. What that means is that for every clinical officer, you work for another 3. And that is why if you go to any outpatient in this country today, you find a clinical officer seeing more than 100 to 150 patients in 8 to 12 hours. You know, it is pure witchcraft, I can assure you, because according to the WHO standards, If you are taking 15 minutes per patient, you are supposed to see around 35 to around 48 patients in 8 hours. We are seeing more than 100. And if you don't see that, the MCA and the other politicians will be on your case. And that is actually not something good, because the repercussions are such that when I get mentally fatigued, and we really need clarity of mind for us to give you a good diagnosis. When we are mentally clouded because of that fatigue, and you become irritable and all those symptoms of fatigue, then that is where you find that people make errors. Not errors because they want, but because these people are being overworked. And that is why we are asking the county governments, and even one of the issues in the return to work agreement and the one that we are discussing is how can we be able to recruit enough, and especially now that we have the Social Health Authority, and the Social Health Authority now will be reimbursing facilities so that we improve the quality of the diagnosis we are giving to our people, even as we tap into that money and capacity build facilities so that Kenyans can be able to get the highest quality of health.
Yes. But Dr. Akwale, what seems to be the problem? Because the impact of this shortage is quite clear and quite evident. But we've also had, in as much as we have this shortage from across all the cadres in the health sector, there are so many who graduate still and they are going to work abroad for for obvious reasons that we know here locally. Is the problem that we don't have enough professionals, or we can't pay them, or what is the problem?
The foundational problem is that we did not invest in health over a period of time. Remember the Abuja Declaration, you need 15% of the GDP. Right now, I think we are somewhere like 4.8 or 5 of that. So look back in the last 50 years, have we been adequately investing in health? And how much have we been apportioning to the human resources? How have we recognized the importance of the human resources for health? So if you don't put money, you are not going to get. But again now, coming to the current context, and we look at universal health coverage, we are now getting a lot of streams of funding. So you have the Social Health Insurance Fund. We still have private insurance funds still also contributing. We then have direct funding from the national government. And we also have some money that goes to the county government. The question then we ask ourselves, what is prioritized under all these funds? I want to repeat again, for me, I would always put human resources as first and foremost. I must say a certain proportion should go to that. Earlier in the show, we talked about the withdrawal of American funding to WHO and to USAID, the pause of that. By the way, some of these donors have been supporting a lot of some of the human resource needs for this country. They have been paying salaries, they have been recruiting. Now with that withdrawal, we are going to see some of those programs, again, these are people we are going to lose. They are not going to be on the payroll. So I would really urge, even as we now continue developing SHA and SHIF, and all these funding streams start coming into play, human resource should be the first charge. And we must move towards ensuring we meet the standard norms as has been established by WHO across all levels of care.
If you're still on that aspect of human resource, having enough clinical officers or medical doctors or nurses is not, we don't stop there. Let's look at also their overall packaging and even prepping them to revolutionize themselves as the changes in the health sector also, keep going by. What level of investment do we also need to do so that, in as much as we one day hopefully get to a point where we have enough professionals in our hospitals, we are also packaging them to be in a position to offer the
best of quality.
Yeah.
Two things. I mentioned one earlier, but the issue of ensuring that they are working in an environment they are feeling comfortable. You have the tools. Yeah. You are able to take. You are able to get the results. You feel comfortable in that working environment. You have your X-ray. You have the other support members of the medical team. That when you need this, the laboratory, the results are there. And that you then quickly make a diagnosis. What Peterson talked about, when you are seeing too many people, the fatigue sets in. You need time that you adequately give to one patient to give quality of care. You need time to rest. You need time also to improve your knowledge and capacity. You need to go for trainings. In fact, my experience is people really appreciate short-term courses. They need to develop their career. They need to go and specialize. They need to have interaction with other people globally. They need to see what is happening outside. This is what starts motivating the health worker. And if the environment improves, there's less of disruption, they don't have to go to the streets, then you'll start seeing a better output of our health workforce.
Peterson, I want to understand the level of engagement that has been there between your union and the Ministry of Health, which represents the government in this whole conversation, and what has come out of those deliberations, because this is not the first time we are talking about clinical officers and industrial action, and the issues you have raised don't seem like they are new items on that particular list. These are, some of them were actually part of, challenges that you raised as grievances before. So what level of engagement really goes on, and what really happens at the end of this conversation? Sometimes we see you go back to work.
Yeah, the problem we have, I can sum it up into lack of goodwill. And of course, goodwill extends all the way to the funding. But in this context of this strike, we have been able to meet everybody that makes decision. From the CS, we have had time to meet the CS, the two PSs. We have met the COG as late as yesterday. I think we're having the meeting with the CS the other day. And there is a little bit of progress, because now the issue of the social health insurance, I think, is being sorted, almost completed now. The clinic officers will be able to see patients through SHA. Can you just imagine that we have to go on a strike so that we can see patients? Yeah, but they're asking us to give them some time of 3 weeks so that they can be able to implement the other things. And yesterday we met and discussed some of our conditions, which of course they agreed on. So we are now to discuss. We are discussing with the advisory council so that it can make a decision on whether we are going to suspend. We cannot call off. We don't trust them that enough to do that. But we might decide to suspend for 3 weeks to give time for us to be able to negotiate the CBA and also the counties to be able to implement promotions and what have you. We have already written to the Treasury a memoranda in terms of the budget, because it's out there, in terms of including the money to convert the UHC, the Global Fund, the CHAP, and the others. But the problem is really funding. And please allow me to just highlight my opinion on the funding, because I think the funding model that we have does not support UHC. As currently fashioned completely. And the reason I say this is because if you look at the plan, the better agenda by the president, we are supposed to prioritize primary health care, and that includes the prevention of disease, so that it can help us lower the cost of health and be able to implement UHC. But when you look at the funding, the primary health care from the community level to level 3 is funded by government. It was given, I think, around 4-point-something billion in the budget. When you go to the 2.75 that we are contributing, which goes into the SHIF, the Social Health Insurance Fund, we have 133 billion. And then we have Emergency and Chronic Care Fund up there. I can't remember the funding. But my point is, if you're saying your priority is in primary health care and prevention of disease, then we can only tell your priority from how you're funding it. You cannot tell me, because SHIF from level 4 upwards is curative. Primary health care, the prevention happens at the primary health care. You're giving it 4 billion. So anybody would look at it and say, we are not preventing disease. Our priority is in curing. And you know, curing disease, curative is like a pit. You can never feel it. You keep throwing money and it will never feel.
But the burden is there. The heat is felt there. Pressure is felt there.
No, actually it is. You see, if you focus into the future, because you cannot stop, of course, funding curative.
Yeah.
But what you can do, in a commensurate manner, you should be able to provide enough resources. For example, if we were to have a nutritionist, you have a clinical officer, you have a public health officer, you have a nurse. You get these people doing family health diagnosis. By this I mean, you do the Cuban model, which we started with. We go into homes, we evaluate them. We'll be able to see who is likely to get NCDs, diabetes, hypertension in the next few years. We'll be able to advise them. We'll be able to go into schools and homes. We will pick those who are malnourished, who are going to come with communicable diseases to the hospital. We'll be able to look at the water sources, how they dispose their excreta and what else through the public health, and we'll be able to advise them. We will not get the diarrheal diseases. So if you are to fund this so that you have this critical resource at the primary health care and doing what they are supposed to do, which is the primary health diagnosis and community diagnosis, in a very few months, probably less than a year, I can assure you that in those facilities, you'll not even see 50% of the people you are seeing before. You are going to bring the cost of health down, and it will be manageable. You'll put that money into equipping the health workers you have with specialized skills. You'll get the specialized equipment. You'll stop Kenyans from going to India. We will use that money to spur our economic growth, and Kenyans will have a better life expectancy. We will have healthy Kenyans, and we'll be able to improve our economy. But if we don't fund primary health care, we continue putting more emphasis on curative care, I can assure you, people will continue going to India and will not be able to manage health.
All right. Doctor, what do you think about his proposal? Because health, just like education, actually takes up a bigger chunk of our budget. But the concern is, how is this money spent? You know, what's the strategy of you know, what allocations we are putting? Okay. I'd like you to respond to his proposal and tell us, from your perspective, what's the best approach to really put money where it's supposed to go when it comes to health?
Yeah, a $6 million question, and an important one. We need to have some trade-offs. There's what we call aspirational. I think what Peterson has said, our long-term period, that is what we really need to do. But currently, we need to appreciate two things. We have a double burden of disease. We have communicable diseases and non-communicable diseases, and therefore we have a challenge of those. And currently we need to have system and structures that would ensure we address that. And one of them is what you are touching on, financing health. And I would want to actually say one of the long-term goals of universal healthcare is to reduce out-of-pocket expenditure. And that will be a very critical indicator to follow over time. Are Kenyans spending less as we go into UHC from their pockets than they were doing 1 year ago, 5 years ago, 10? In fact, we must be monitoring to say, in 10 years' time, there should be a reduction of out-of-pocket expenditure of this proportion. I'm seeing a number of indices, like how many people have been enrolled. Those are process indicators. But we also need indicators that really touch on the user, including out-of-pocket expenditure. We need, for example, to know how many people with diabetes have benefited from SHA, how many people with who have got accidents have benefited from SHA. And now let me come to really what you need to consider as a trade-off. And recall back in my days working in Kitale Hospital as a medical officer of health, one Friday we made sure Fridays you want to relax, so you say you've bought everything is in place, you go through the weekend. And on that Friday evening, you hear this matatu accident. 2 matatus, 30 patients have come, critical conditions, you need everything you bought is used, you don't even have enough, you have to refer some patients to Eldoret. That is a true example that we used to say. So, you know, road traffic accidents are non-communicable diseases, but they use a lot of resources. And at that time, your focus is to save lives. You know, at that point, you'll not be saying, now let the money go for prevention. Now you're preventing death at that point.
That is where the pressure is.
That's where the pressure is. So the trade-off should be that you must be adequately prepared to save lives, whether it is from NCDs, any other emergencies, chronic emergencies, but you are slowly also building your preventive program so that in 5-10 years, and that's why I've really said, if we look at UHC as a journey, 10 years and beyond, and not a 1 year, 3 month thing, then we may just start getting certain things right.
But it seems like we've been on this journey for quite a while. UHC was rolled out a while back. But yeah, and gentlemen, we've run out of time, but there's something somebody has sent me here. I'd like to hear your thoughts, Peterson.
Yeah.
Yesterday, Cabinet, sat and made a decision to merge certain state corporations and streamline others. And one of the professional bodies that seems to have been affected include some that touch on the health sector. And this is a directive that all professional bodies currently categorized as state corporations should be declassified and should not be financed through budgetary allocations. Some among them include the Clinical Officers Authority, Council of Institute of Nutritionists and Dietitians, Kenya Health Professionals Oversight Authority, Kenya Medical Laboratory Technicians and Technologists Board, the Kenya Medical Practitioners and Dentists Council, and the Public Health Officers and Technicians Council, Nursing Councils of Kenya, among others. But I've just cited the ones that touch on the health sector, and the Clinical Officers Authority is also under this category. What are your thoughts about it being included among those that will not be funded or financed through budgetary allocations? What impact are we looking at?
Yeah, of course, it's going to have an impact in the regulation of health in the country, because all the bodies together that you have mentioned, they work together to regulate the type of healthcare and the quality of the practitioners that we get. So it's going to affect how, of course, they carry out their functions, because they usually assess and accredit training institutions, follow through to ensure curriculum is followed and that the products are competent. Then they follow you during practice, ensure that you're practicing the way you're supposed to. And they do this, of course, through sometimes workshops to do curriculums. Sometimes they do random checks and inspections and supervisions. And these are going to be affected across the board. So the quality, it's going to affect probably the quality of health we get in the long term. But I think a good number of them, they have, their funding comes from the licensure of the practitioner. So they may not be that very much affected. But I feel for some, like the Kenya Health Professional Oversight Authority is a supervisor of the other regulatory bodies. It doesn't have direct income from practitioners because it doesn't give licenses. So it's actually going to crumble. And the reason as to why it was brought in place, it was actually the Quality of Care Authority that I hear that they want to legislate another one, because it's supposed to ensure that these other regulatory bodies maintain the quality of health through their regulation of training, regulation of practice, and their licensure to ensure that these people are updated. So for some of them, I think if I had an opportunity I would advise against, like the KH-POA, because once you crumble the KH-POA, then they are unable to supervise the others, and then the others may do what they want. But generally, this is going to affect the quality of the healthcare that we get in future.
All right. We've run out of time. As we close, I'd like to allow you to give us your closing remarks. Let me start with you, Peterson, then we close with Daktari. So what's the way forward? At least you've told us there are some developments going on with regards to your grievances, but now what is the next step of action that the union is going to take as the days go by?
Yeah, I think what we are looking at is we want the return to work agreement fully implemented in the next 21 days. We will be communicating later in the day whether the advisory council, it's the top making decision of the union, whether it then okays that decision, that we give a 21 days break as we engage with the employers to ensure that that is done. But I think for me overall, my message, even I close, I would like to address my message to the President. Your Excellency, there are people who are failing you. And these people are in the Social Health Authority. Please get people who understand universal health coverage, who understand the reason as to why we have Social Health Authority, so that they can help you deliver your mandate to Kenyans, and especially not to embarrass you because the president is promising things because he knows in the regulation he has provided that. But the other people who are giving him some self-sabotaging administrative policies that are making people not access health. And that is why sometimes you'll find the president is telling people SHA is working, and they're telling him no, because for him what he knows at the policy level is supposed to work. But the people who are implementing are a problem.
All right. Daktari, your final thoughts?
Yeah, my final thought, I must just say, SHA is like a baby that has been given to us. And we need to ensure that this baby grows, it meets its milestones, and that it grows to become an adult that will be useful to the nation. We will all benefit from SHA. This is something we've been yearning for. Medical costs can be very catastrophic. They can send people into poverty and into the graves much earlier. So what I'm calling upon is all stakeholders. Everybody needs to be involved in this issue of universal health coverage. What contributions do we give? But we must have very strong leadership to ensure that this program succeeds. We must have a very clear monitoring and evaluation framework. We must be quick to learn lessons, first to identify the challenges, the weaknesses, the success stories, and build on them.
All right. Thank you so much for creating time for us, gentlemen. I have been engaging this morning. Dr. Willy Sahwale is a public health expert, and we have also been having this conversation with Peterson Wachira, Chairperson, Kenya Union of Clinical Officers. We were expecting Dr. Brian Lishenga, Chairperson, Rural and Urban Private Hospitals Association, but unfortunately he couldn't join us. But that's how we wrap it up. Thank you so much also for creating time for us this morning. Since we started daybreak till now, we do not take your time and company for granted. My name is Safina Ching. Have a lovely day ahead.